Good morning, everybody, to our weekly resident lecture. I would like to introduce Janina Eden. She is our fifth-year resident. She will talk today on liver surgery, modern treatment of liver surgery, which is basically a little bit a summary of the paper which we published in Nature Reviews. And we divided the talk. She will come back next week again in liver surgery, and the next week we will talk about liver transplantation for the treatment of malignant liver tumors. All right, enjoy.
Thank you so much, Professor Petrovsky, for the kind introduction. As it was said before, I'm going to talk about modern therapeutic approaches for the treatment of liver tumors. And let's go over the outline real quick. We will talk about different types of malignant liver tumors. We will talk about modern techniques in liver surgery and compare it now and then. We will talk about ablative approaches and indications for liver surgery, and we will focus on surgical approaches, and then there will be a quick summary. Let's start with primary hepatic liver tumors. First to mention is the HCC, which is the hepatocellular carcinoma. It is the fifth most common cancer in the world. It is the most common type of primary liver cancer worldwide, more common in Asia than in Europe. It occurs most often in people with chronic liver diseases such as hepatitis, NASH, cirrhosis, and fibrosis. And the main risk factor is liver cirrhosis, which is present in 80% of all HCC livers. Now, there's a 1 to 5% risk of HCC in patients with cirrhotic livers. And if you look at the picture down below, you can see on that left image down there, the rim enhancement on delayed post-contrast imaging causing a capsule appearance, and that is very specific for the HCC. And on the right-hand side, you can see what it looks like after resection. As for the PHC, and most of you might know this tumor as the Klatskin tumor, it originates from the epithelial cells of the bile duct. PSC is a common risk factor. It has the worst prognosis of all CCCs, and it is the most common type of all CCCs, and it is the second most common type of all primary liver malignancies. There is a rising incidence reported, and what is important to know is that there is a difference between the HCC, which is the way it presents itself on CT scans. It's not visible there, not always, but in most cases. But what you do see is an indirect sign, or might see is an indirect sign, such as a thickening and enhancement of the bile duct wall, which is marked by the arrow. And that's often the only sign of this tumor. If you do want a better diagnosis or more precise diagnosis, you might want to do an ERCP or an MRCP. As for the ICC, the intrahepatic cholangiocarcinoma, that belongs to a subtype of family of aggressive cholangiocarcinomas that arise from cholangiocytes of the biliary tree. And ICCs are rare. They account for roughly 1/4 of all cholangiocarcinomas, and risk factors are choledochal cysts, cholangitis, PSC, parasites, but mostly they appear de novo. And similar to the HCC, this tumor is very much present on scans, PET-CT scans, as well as CT scans, regular ones. Let's go over to the secondary hepatic liver tumors. And first to mention are the colorectal liver metastases. The liver is the #1 metastatic site in CRC patients. About 1/4 of all patients will develop colorectal liver metastases eventually, either synchronously or metachronously, and it is the most common liver malignancy in general. And there are very high recurrence rates reported even after resection. And a difference between all the other tumors we've talked about so far is that the lesions appear multiples, not singular lesions. It doesn't mean that the other tumors I've talked about cannot have multiple lesions, but it's less common. And also, another main difference is that the liver itself is healthy because there's usually no underlying liver disease because the liver is not the primary. Let's talk about NET metastases quickly. They're generally rare. 80% of NETs found in the liver are metastatic. Primary hepatic neuroendocrine tumors do exist. They're called PH-NETs, but they're even more rare. A difference between this tumor and the other tumor entities, there is a prolonged survival compared to all the other tumors we've discussed so far due to their usually indolent course. And therefore, indication for surgery is very restrictive. Now let's go over to modern techniques in liver surgery now and then. The liver has the capability of rebuilding, and that offers the feasibility of major resection. Now, the main hurdle in early liver surgery was uncontrolled bleeding rather than insufficient volume or function. And nowadays, that is solved by precise knowledge of segmental liver anatomy, application of low central venous pressure and anesthesia, and inflow occlusion. And that leaves room for new resection techniques and novel approaches. But with that, the question arises, which treatment is the right one, and is there even such a thing as the right method? And that's exactly the question members of our department asked themselves. And they decided to present 10 cases of colorectal liver metastases patients to 43 expert liver surgeons from 23 countries and 4 continents. And the people or the surgeon it was presented to, they really are experts in their field. Just to mention a few, there's Santibanez from Argentina, there's Peter Lodge from England, Human Fong from the US, Professor Clavier from Switzerland. And what they found is that there really is no consensus on how to treat these patients and what treatment method is the right one. Each and every one decided differently on how to treat these patients that were presented to them. And that's exactly why it's so important to talk about those methods in detail, to get to get to know them better and to decide on which one to use on each specific patient. Let's start with ablative approaches: thermal ablation, non-thermal ablation. Thermal ablation first. We differentiate between microwave ablation and radiofrequency ablation, and the energy type used is electromagnetic energy. Mechanism of destruction, heat coagulation, and probes, while they are placed in the tumor center. And what is important to know is that the maximum tumor diameter is limited to 5 centimeters or 3 centimeters each. And I want you to keep that in mind. Now, the local recurrence rates range from 5 to 20% or 5 to 30% respectively. And the indications are single or multiple tumors for both methods, and contraindication, important as well, are superficial tumors or vicinity of large vessels or bile ducts. And advantages for microwave ablation is a better prediction of ablation zone, faster heating, less sensitive to heat sink effect, and I will get to that in a minute, when you compare it with radiofrequency, whereas radiofrequency supposedly is better for small tumors. And the main limitation is thermal injury, and the heat sink effect describes thermal damage to nearby structures, and thus those techniques should not be used in close proximity to major blood vessels or to the biliary tract because of its risk of major bleeding, portal vein thrombosis, bile leaks, cholestasis. Now, if you compare the oncological results of this procedure to surgical resection, you will find that they fail to show superiority to surgical resection. And it showed especially bad results in larger lesions, and then also there are high recurrence rates reported. About 2/3 of all patients, for example, with colorectal liver metastases had a recurrence. Let's talk about non-thermal ablation. I'm not going to talk about all of these things, but just to mention a few, we differentiate between irreversible electroporation and reversible electroporation. Irreversible electroporation you might better know as the Nano-knife procedure, as you can see on the right-hand side. The mechanism of destruction, either cell membrane disruption or increased cell membrane permeability. And again, the maximum tumor diameter is limited to 5 centimeters or 4 centimeters respectively. And the local recurrence rates are, well, they range from 5 to 45%. 45 is not that low for irreversible electroporation. And as for indications, contraindications, advantages and limitations, you will hear about that on the next slide, this one. So the pros of this procedure, there is no heat sink effect. That means we have the possibility to target tumors in close proximity to biliary structures and vessels. And it is a useful tool in combination with surgery, especially as part of a 2-stage procedure. Now the cons, we do not have that much data on this procedure. It is very time consuming. We need general anesthesia and there is a need for precise needle placement. to get good results. And then there's a risk of cardiac events. In 40% of all cases, those do occur, and many of our patients are quite sick, and therefore, if they do have an underlying cardiac disease, they might not be the best patients for this option. And slightly higher recurrence rates have been reported as well. And again, to sum it up, I want you to, down below, it's not that large, but still, I do want to say that the tumor diameter is of importance because that one is limited to a maximum of 5 centimeters for all techniques, for all ablation techniques. And as we know, many of our patients have tumors that are much larger than those 5 centimeters. Now, surgical approaches. The indications for liver surgery. As of now, liver surgery remains the best option for long-term patient survival and cure for the mentioned primary and secondary liver tumors. As for NET metastases, there's a difference. Incomplete tumor resection, such as CRS, might be beneficial, especially for symptom relief or for hormone-active tumors resistant to medical treatment. Let's talk about the role of minimally invasive robotic surgery for a minute. Laparoscopic liver resection has become standard of care in many centers around the world, and data suggests equivalent oncological results and improved postoperative recovery when you compare it with open liver surgery. Now, the limitations of this procedure is 1, the degree of freedom, and 2, vision and precision of motion. Robotic surgery seems to be a promising alternative method because of its steep learning curve that's equivalent to the laparoscopic approach, the greater vision, precision, and range of motion that it guarantees, and the costs, while they might be of concern for institutions with limited resources, but an outcome study in the US, for example, reported favorable costs. Let's talk about the different types of liver resection. And let's talk about parenchyma-sparing liver resection first. It relies on the principle of preserving non-tumorous liver tissue, and it can be supported by tissue-augmenting interventions such as PVE, portal vein embolization, or ligation, and 2-stage hepatectomy. It can be performed both through minimally invasive and open surgery, and it can be performed by itself or in combination with ablation techniques. And it requires profound knowledge of segmental liver anatomy and expertise in intraoperative ultrasonography. And if you look at the picture, and I just wanted to show it to you because I do wanted to show you the technique. What we do when we do parenchyma-sparing liver surgeries, we take out the tumors one by one by one. And the number of tumors is not limited per se. There are surgeons out there that will tackle livers that are as affected as the one you can see on the right side. Now, the pros and cons of this procedure. The pros, there is a proven higher tolerability of liver surgery. There's a lower risk of postoperative liver failure. There's a potentially higher feasibility of repeat liver surgery in the event of tumor recurrence. And it does not compromise long-term oncological outcome when we compare it with anatomic or major liver resections. The cons, there is a higher incidence of biliary leaks, that's proven. The total number of liver tumors removed is low, question mark, because I just said before, there are surgeons out there who do not depend on the number of tumors. And then it's less promising for multiple tumors or in the scenario of disappearing tumor lesions after chemotherapy. And that's logical because if you don't see the tumor anymore, then it's hard to take it out, even though it might still exist microscopically. Now, extending the boundaries of resectability. This relies or is based on 2 principles. 1, the complete removal of the tumor, and 2, to keep a sufficient future liver remnant. In a healthy liver, I want you to look at the picture on the right-hand side. In a healthy liver, we usually go or opt for a future liver remnant of about 20%. And that is very optimistic. We usually go for 25 to 30%. In a diseased liver, meaning a liver suffering from fibrosis or cirrhosis, we opt for a larger future liver remnant of about 30 to 40%. And in chemotherapy pre-treated livers, due to its high toxicity to the liver, we need to go for an even larger future liver remnant of about 38 to 40%. So what strategies are available out there? We have the PVE, the portal vein embolization, or ligation for that matter, the two-stage hepatectomy, and the ALPS procedure and its variations, and we will go over them one by one. Let's talk about the principle of portal vein occlusion first. So you see the liver, you have the left lobe, you have the right lobe. The right lobe is tumor bearing. What we're going to do is we're going to occlude the right portion of the portal vein, the right portal vein. And what's going to happen is that there's an increased blood flow to the left side of the liver and a decreased blood flow to the right side, a non-existing blood flow. And within a matter of 3 to 4 weeks, the left lobe of the liver grows and the right side shrinks. A more elegant way maybe to do the occlusion might be via embolization, as we don't have to open the patient up. And left images top to bottom pre-intervention, and right images top to bottom post-intervention. And I want you to look at the right picture on the top. We did our embolization. We waited for 3 weeks approximately, and we do see that there are vessels growing. And if you look at the picture on the bottom, you can see that the left lobe of the liver has grown and the right side didn't only decrease in size, but you can also see a necrotic part down there. Now, an advancement of the original portal vein occlusion procedure might be an additional embolization of the hepatic vein, in addition to the portal vein, a so-called double embolization, as it may promote faster regeneration. The data in this modification is limited but promising. Now, usually the occlusion procedures we just heard about are part of a two-stage procedure. And when do we use a two-stage procedure? We only use it when primary resection is not possible. So, what are the requirements for a procedure like that? One, we need to have unresectable bilobar liver tumors. There needs to be prior response to neoadjuvant chemotherapy, and one side needs to be less or not affected at all. Let's talk about the portal vein embolization and the two-stage hepatectomy combined. You know this image by now. Tumor on the right side, more tumor, on the left side, less tumor. So what we're going to do is we do our portal vein occlusion via ligation or embolization, it doesn't matter, and then we do a tumorectomy of the less affected lobe. And then we wait for approximately 3 to 4 weeks. And then we have these increase of size of the left lobe, decrease of size of the right lobe, we know that by now. And then we can do our right hemihepatectomy in this case. Now, the major problem we're facing when doing this procedure is the dropout rate in two-stage hepatectomy. So between stage 1 and stage 2, there's a time period of 3 to 4 weeks. And within that time period, 25 to 40% of all patients will drop out. And that is due to insufficient hypertrophy, one, and disease progression. And so these patients will never undergo stage 2 and never will have the curative surgery. And that is exactly why we will talk about a modification of the procedure that was actually discovered by coincidence, and it's called the ALPS procedure. Now, you know this image by now, liver, right side again, more affected than the left side. We do the portal vein ligature, we do the tumorectomy, and all of that is not new. But now we do a split of the liver, a total split of the liver for the ALPS procedure. So we basically have 2 parts. And then we wait, and that's the difference between the ALPS procedure and the other procedure. We only wait 1 week, and already a hypertrophy of the future liver remnant happens, and we have a total volume increase of about 30%. So then we can go and do our stage 1 procedure, which is, in this case, the right hemihepatectomy. And we have a total volume increase, and that's important, of about 50 to 200%. Now, that just serves as a visual comparison between the two-stage hepatectomy and the ALPS procedure, and it's not. It should be a total split of the liver, actually. What I want you to show is that the liver doesn't really grow that much bigger in the ALPS procedure, but it grows bigger faster, and I think that's a key message. So, and I did want to show you also this Scandinavian multi-center RCT because of the results that are quite staggering. We have resection in our all resection rates for the ALPS procedure of 92 and 77%. And in comparison to that, the two-stage hepatectomy results are not slightly as good. And that is something to keep in mind as well. Now, as with any procedure, if there is an upside to a procedure, there usually is a downside as well. And the problem with the ALPS procedure is the relatively high morbidity, which leaves us in need for an advancement of this otherwise pretty successful procedure. And that is where the PALPS procedure comes into play. And it was introduced in 2013 at our institution. And what it is a switch from complete transection to a well-defined partial transection of about 50% of the entire transection surface. And the hypothesis behind it is that the PALPS procedure is safer and achieves similar rapid hypertrophy. And we tried to prove that by doing a clinical trial. The study design, well, it was non-randomized, non-matched, only included 18 patients, but the results were interesting nonetheless. Showed a rapid hypertrophy that was almost similar to the ALPS procedure. But what is more important is that there was literally zero postoperative mortality and a lower morbidity. And most of us have not even seen this procedure being done. And so I did want to show you how it looks like in real life. All right. So that's how it looks like, and it's pretty impressive, I think. Now, one last slide, conventional technique versus ALPS and its variations. The main difference, and I think we know this by now, is that the liver parenchyma is transected along the intended line of resection at the beginning of step 1. And the advantages are volume increase, shorter interstage intervals, higher general resection rate and our all resection rate, and longer median overall survival. Now, the indications for the ALPS procedure are extensive liver tumors, a small future liver remnant that's to be expected, and PVE failure. Okay, lengthy talk. Let's close with a summary. So what are our key messages? The key for successful liver tumor treatment is a multimodal approach. And even though I haven't even talked about all the procedures that are out there, such as chemotherapy or the pump, we need to remind us that even though surgery is, as for now, the only curative option we have, all the other procedures are of importance as well, and they help us getting better results in the end. And that leads me to my second point. Only continuous research guarantees improvement. On many of these procedures, we don't have sufficient data yet. And that is why it is so important to continue the research. And even though we're surgeons and our main goal probably is to operate, we're kind of obligated to do research as well and to invest in research. And then there is no one-size-fits-all approach. And what that means is, even though people might look like on CT scans, they're still individuals. And behind every patient or behind every CT scan, there's an individual. And that means they come with their own subset of problems and their own comorbidities and their own specifics and especially their own wishes and ideas regarding the treatment. And we need to take that into account, and we need to take that seriously. And then, last but not least, we need to maintain the mutual exchange of ideas and viewpoints and research between the specialties involved in the treatment of patients. And we're already doing it by holding our interdisciplinary tumor board conferences, where we discuss each and every case with everyone involved. So we need radiologists, we need interventional radiologists and oncologists and pathologists. We need all of them. And it's a team effort. Without working as a team, we will not get as good of results that we're getting right now. And that was it.
Yeah, Janina, thank you very much for this presentation. A lot of information. I think you did very well. I will encourage, maybe a little bit selfish, to read this review for several reasons. Not only because it's from our group here, but this is really, as you summarized very well at the end, it covers the different topics. So it's written by oncologists, by nuclear medicine, and multidisciplinary people. And this is the way today clearly to treat complex patients with liver tumors. Absolutely no doubt. In addition, if you're in a center who benefit from transplant, I think you present that next week, this is becoming more and more an option. It was no option at the beginning or little option now. We are learning more, doing that better, and this is another part that I think we will listen to you next week. From all the message you give, I think there's been a switch in the 90s or early 2000 where it would have been very difficult to write this review because we really thought about the tumors first. I mean, the colorectal tumor, for example, we're counting the number of tumors, the size, and that was the indication period, going from 1 to 3, etc. And that was the main factor. Today, and then you summarized that very well, this is over. There are two questions we ask when we see colorectal or many other tumors. Can we take it out? And we don't count or whatever. We look at vessel, many different aspects, need to be done by expert, of course. And the key factor now is to prevent liver failure. If you take too much tissue, then patient will not survive and we go liver failure. And as you showed, there's many techniques today. The ALPS is one, portal vein embolization, etc. Many techniques to try to prevent this liver failure. So the goal of all of that is to prevent, when you take a lot of tissue, that there is enough functional tissue at the end. The other point, and I think you also covered that here, that need to be done in center of expertise. We cannot overemphasize that. I mean, it looks sometimes very selfish, etc., but from the patient perspective, it's absolutely clear. Patients need to go in centers where there are expertise, not just a good surgeon doing the case, but where there is a lot of people. And even in that situation, like a football team, we are not good everywhere or expertise, so you have dominant team, and we can see in the world there's dominant interventional radiologists or surgeon, etc., and you try to have the best team and exchange and present the cases. But the local expertise is also very important in treating these patients and this. So it's very complex as you try to cover all the different. This review was done mostly on the therapy when we go for tumors, because you still need to adjust. And I think today is still right. But of course, it's a very, very complex. Center volume is also important in this topic. So you did very well. I don't have much to add. And if there is any questions.
Thank you. Great talk. Just one question to the NanoKnife procedure. You said that the cardiac morbidity is around 40%. And so what cardiac morbidity are you talking about, and what's the mechanism?
I mean, what we know is that there is high risk of cardiac events to occur. And with that, we mean arrhythmias. It's and the reason for that, maybe you want to say something or add something to that?
No, I mean, this is a good question. We bought, in fact, this machine here. We have it. Was a lot of enthusiasm at the beginning. And it's done in two situations now. I mean, also for pancreas or whatever is non-resectable lesions. This is electroporation. So basically you do irreversible, that's the name, of membrane shift of electrolyte in the cells and they die. And the beauty of that, at least the beginning, we are learning more, is that it does not affect bile duct, vessel, etc. So tumor that are encasing the celiac trunk or the hepatic vein, then you can go and take that out or remove it by ablation to the electropораtions. Now we are learning. There is a database on that, a registry, which is in Louisville, in fact, manage that. So we are learning. We've published also some of the data on this. Number one, it's expensive. Number two, it needs expertise. The needles are very soft, so very difficult to place. And it's also highly dependent of the people they do it. So today we use it often or sometimes as an adjunct. When we resect, we can use resection combined with microwave, combined with electroporation sometimes. The data on, for example, local recurrence in pancreatic cancer, I'm not even aware of probably the last data from the registry that can be done that has not really end up in increase in survival in these patients. So I think it's good to have it. It should be done again in center with experience doing many other therapy and not only this mechanism. But we still have it and we use on occasion.
Perhaps to answer your question is on cardiac events. This was your question. So this is a mechanism where you use electric power, which changed the field very quickly. So if you have patients who come with cardiac comorbidities, especially arrhythmias, these patients are often not suitable for nanoknife. So therefore, every patient needs a cardiac workup before we consider nanoknife. Also, it's important you could have intraoperative complications with arrhythmias. Therefore, the pulse has to be synchronized with a heart rate so that we don't get arrhythmias during surgery. This is what, yeah. And I think I also want to comment a little bit what Professor Claver already said. You did very well. It was very difficult when we prepared this talk because you cover a lot. So we basically spoke about surgery and ablation, and it shows also a little bit what we wrote, but also what we do here in Zurich. So especially for Alps, what we do, and also your presentation was very well done. Yeah. Another question?
Yeah, I would have a question about your ablation techniques. And why is it limited to a maximum tumor size? Can't you stick your needle twice? And can you combine thermal and non-thermal ablation techniques for complicated tumors?
Good question. If the tumor is large, yes, you can do 2 ablations, but studies show that the rate of complete ablation decreases with size of tumor. This is shown in different studies. So, and as you know, if you have a 2 centimeter lesion, you bring the needle right in the middle and you have a ablation zone of 3 or 4 centimeter, the tumor is gone. And if you have a 5 centimeter, you need a long and long period and higher energy to ablate. And often these things are not complete, so there is some missed margin. And this is just shown in studies that with increased size, the recurrence rate increases.